It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. It's almost July of 25, and you guys are starting your new fellowship programs, and boards will be coming up in September. At least the ABA boards. And I just wanted to do some more board prep. So this is an episode, Herpes Zoster and postherpetic neuralgia is a topic. And I'm actually not just here to prepare you for your boards. I'm also looking for the latest info just to help me treat my patients. Because this is a notoriously difficult disease to treat. By the way, Aspen is coming up in July. We have Pain Week in September. I'm going to be teaching ultrasound and regenerative medicine. I'm lecturing on there. And NICIP, Latin American Pain Society, all these great conferences. If you happen to be interested, sign up at nrappain.org and create an account. You'll get access to our community where we talk about regenerative medicine, ultrasound-guided pain medicine or regional anesthesia, and of course board prep. And find out what was asked on the boards, just keywords, not questions, of course. And I am still doing ultrasound training in New York and elsewhere. So if you're interested, just sign up to one of our conferences, courses, We have one July 12th in Manhattan, then October 4th. And then you could do private shadowing if you're still interested. So anyway, let's get into it. Postherpetic neuralgia is typically a unilateral chronic pain in one or more dermatomes after acute herpes zoster infection. The incidence of acute herpes zoster ranges between 3 and 5 patients per 1,000 person years. In 1 out of 4 patients, acute herpes zoster related pain will transition into postherpetic neuralgia, which is a pretty high, percentage. This can be very disabling, reduce quality of life. Patients, it won't kill them, but they'll wish they're dead because it's really that miserable. So this is a big literature review over the treatments, and they go over the analgesics, according to the WHO pain ladder, tricyclics, nortriptyline, antiepileptic drugs such as gabapentin. If the pain is not significantly reduced, interventional treatments such as epidural injections with local anesthetics and corticosteroids or pulsed radiofrequency of the dorsal root ganglion are options. Treatment of postherpetic neuralgia is preferably with transdermal capsaicin, lidocaine, or oral drugs such as antidepressants or antiepileptics. So they give a little history here about, and there's going to be a link in the show notes, so just check that out. It's a really nice, well-written article. The 3 phases during herpes zoster reactivation are defined as acute herpes zoster-related pain, subacute herpes zoster-related pain, and postherpetic neuralgia. Acute herpes zoster-related pain lasts for a maximum of 30 days. Subacute herpes zoster herpetic neuralgia is defined as pain that endures after the healing of the vesicles, but disappears within 3 months after the onset. There's still no consensus on the definition of postherpetic neuralgia, but it's typically defined as pain that continues after 3 months of the disease. The acute herpes zoster pain often begins with prodromal pain starting a few days before the appearance of the rash. The incidence of herpes zoster ranges between 3 and 5 patients per 1,000 person years, and it tends to resolve spontaneously with time in most patients and leads to postherpetic neuralgia in approximately 5 to 30%, which is a huge range. Risk factors: older age, female sex, immunosuppression, prodromal pain, suffering from a severe rash, and greater acute pain severity. Herpes zoster-induced neuritis can have different clinical manifestations, including a mosaic of somatosensory symptoms: burning, deep, aching pain, tingling, itching, stabbing, often associated with tactile and cold allodynia. It can be debilitating, have an impact on both physical and emotional functioning, and causing a decreased quality of life, leads to fatigue, insomnia, depression, anorexia, anxiety, and emotional distress. It's therefore important to explore methods for prevention of development of postherpetic neuralgia to optimize pain treatment for both subacute herpes zoster related pain and postherpetic neuralgia. So they did a literature review to update on previous practical guidelines that were published last in 2011. This is a recent article. And to provide an overview of the terminology. This article, by the way, is from 2024. So in terms of pathophysiology, there's a hypothesis that it involves sensitization of the peripheral and sensory nerves from damage. Abnormal sensitization occurs when peripheral nerves get damaged. Inflammatory mediators reduce the stimulus threshold of nociceptors and increase responsiveness of nociceptors to stimulation. This results in pathological spontaneous discharges, lowest thresholds for thermal and mechanical stimuli, and hyperalgesia. Central sensitization is a result of peripheral nociceptor hyperactivity leading to plastic changes in the central nervous system that involve amplification of pain signals and reduced inhibition. Nerve damage in postherpetic neuralgia patients is a result of neuronal death due to severe inflammatory stimuli or secondary to neuronal swelling accompanying the inflammation. This can compress the sensory ganglion in the intervertebral foramina, resulting in ischemia and nerve tissue damage. Motor defects occur in 0.05% of patients with herpes zoster, observed as abdominal pseudohernias or motor weakness of the limbs limited to the affected myotome. This is thought to be caused directly by viral spread from the DRG to the anterior horn cells or adjacent motor nerve roots. There are different phenotypes, and you could do phenotyping to determine treatment. There may be several factors, including physical exam findings like allodynia, thermal hypersensitivity, skin biopsy, and cutaneous reaction to histamine may vary. There are several ways to classify the phenotypes, one of which the categorizes patients into three subtypes: sensory loss, which is the most common, thermal gain, and thermal loss with mechanical gain. In terms of mechanistic categorization, the irritable nociceptor phenotype characterized by preserved sensation, profound dynamic mechanical allodynia, and reduced pressure pain threshold, and relief of pain with local anesthetic infiltration. This phenotype is believed to be due to upregulation of sodium channels and has been shown to be responsive to topical capsaicin and lidocaine and sodium channel blockers such as oxcarbazine. A deafferentation phenotype may arise from destruction of neurons by the virus in the DRG. This phenotype is characterized by sensory loss, including thermal and vibratory sensation, without prominent thermal allodynia. However, mechanical allodynia can occur secondary to A-beta fibers activating spinothalamic pathways known as phenotypic switches, along with pressure hyperalgesia and temporal summation, suggesting central sensitization. In one study, this phenotype was present in 10.8% of individuals. In individuals with deafferentation pain, in addition to gabapentinoids and antidepressants, neuromodulatory therapies such as repetitive transcranial magnetic stimulation may prove beneficial. So when it comes to diagnosis, of course, physical exam is pretty important. It's based on the rash, redness, papules, and vesicles in the painful dermatomes. Healing vesicles may show crust formation. The rash is generally unilateral and does not cross the midline of the body. In postherpetic neuralgia patients, scarring, hyper or hypopigmentation is often visible. Allodynia is present in 45 to 75% of the affected patients, as described with pseudo hernia or motor weakness in a limb, and can be a motor complication occasionally detected during physical exam. In patients with postherpetic neuralgia, a mosaic of somatosensory alterations can occur. Sensory alterations can manifest as hyperalgesia, allodynia, and sensory loss, which can be quantified by quantitative sensory testing. It assesses somatosensory functions, thermal detection, thresholds for perception of cold, warmth, and paradoxical heat sensations. Thermal pain thresholds for cold and hot stimuli, mechanical detection thresholds for touch and vibration, mechanical pain sensitivity and tolerance to pain stimuli. It can also provide clues regarding underlying mechanisms of pain. Impaired conditioned pain modulation and temporal summation suggest central sensitization, and about the type of nerve damage, A beta, A delta, C fibers, etc., and the surviving afferent neurons. So prevention of acute herpes zoster, well, the risk of it is increasing with the reduction in immunity. Vaccinations can boost immunity for varicella zoster virus. Studies evaluating Shingrix, a vaccine for herpes zoster, showed 97% effectiveness in preventing herpes zoster in patients 50 to 69 years old with healthy immune systems. In patients older than 70 years, it was 89% effective. Shingrix is in preventing postherpetic neuralgia development was 89 to 91% in patients with healthy immune systems and 68 to 91% in those with weakened or underlying conditions. If a patient has had herpes zoster in the past, Shingrix has been shown to prevent future occurrences of shingles. Thus, vaccination is a promising method for both herpes zoster for preventing herpes zoster and postherpetic neuralgia. So, treatment objectives: you want to relieve pain from acute herpes zoster, reduce severity, duration of pain, accelerating recovery of epidermal defects, and preventing secondary infections. Preventing or reducing these diseases the disease burden of postherpetic neuralgia. The treatment objectives are pain alleviation and improved quality of life. So, psychotherapy, procedures available, NSAIDs, opiates, antidepressants, antiepileptics, NMDA antagonists, and topical agents such as capsaicin, lidocaine, and local anesthetics. Additionally, there are multiple interventional treatments such as epidurals, pulse radiofrequency ablation, pulse radiofrequency, not the ablation part, nerve blocks, spinal cord stimulation, but there's still no consensus on what's the most effective. And by the way, I saw a patient yesterday with postherpetic neuralgia of the trigeminal nerve, facial pain, and I treat this. I see this. I'm doing this podcast just to make sure that I'm giving her the best care possible because I wanted to brush up on this. It's not like sciatica that I'm seeing over and over and over. This is something that I see a few cases here and there. Antiviral drugs should be started within 72 hours of the clinical onsets. We're talking about the acyclovirs, famciclovirs, and valacyclovir. There is no evidence for any effectiveness after 72 hours in patients who have uncomplicated herpes zoster. In immunocompromised patients, the dosages of famciclovir and valacyclovir are 500 and 1,000 milligrams. That's 3 times per day for 7 days. That's in immunocompetent patients, those doses. In the immunocompromised, the dosage is famciclovir is 1,000 milligrams 3 times a day for 10 days. So you're just extending it from 7 to 10 days. While acyclovir should be given IV in the immunocompromised. Antiviral medication accelerates the disappearance of vesicles and crusts and healing of skin lesions and prevents new lesions from forming. By inhibiting viral replication, antiviral therapy is likely to reduce nerve damage, resulting in reduced incidence of postherpetic neuralgia, and it should be started as soon as possible. Corticosteroids, in addition to antiviral medications, may reduce the severity of acute zoster-related pain. However, increased healing of skin lesions was not observed in one study. A Cochrane review evaluated the effect of oral corticosteroids in the prevention of postherpetic neuralgia, and they were found to be ineffective. Opioids, alongside antivirals, is a common therapy for controlling the pain of acute herpes zoster, and in review, the use of opioids provides significant alleviation of the pain. For acute herpes zoster-related pain, tramadol has a number needed to treat for 50% pain reduction of 4.7, and stronger opioids have a number needed to treat of 4.3. Long-term use of opioids has serious side effects, as we all know, dependency, etc. Methadone, an NMDA receptor antagonist, is used in acute and chronic pain management. However, there's no randomized controlled trials of determining the efficacy in acute herpes zoster pain or postherpetic neuralgia, but as an NMDA receptor antagonist that also inhibits the uptake of norepinephrine and serotonin, methadone can modulate pain stimuli, resulting in decreased development of hyperalgesia and opioid tolerance. Despite the auspicious effects of methadone, similar to other opioids, its side effects include constipation, nausea, sedation. We all know that QT prolongation that can trigger torsade du poids. Antidepressants, first-line therapy for postherpetic neuralgia, both tricyclics such as amitriptyline, nortriptyline, serotonin, norepinephrine reuptake inhibitors, and serotonin, the SNRIs, duloxetine, venlafaxine. The tricyclics have a number needed to treat of 3, and for 50% pain reduction, SNRIs have a number needed to treat of 6.4 based on several controlled trials. Antiepileptics also play a huge role in this. Gabapentin, pregabalin. 2 trials measured the effect of gabapentin on postherpetic neuralgia, concluded that it was effective compared to placebo. The pooled number to treat was 4.4. In addition, the authors pooled the data from 2 trials of pregabalin versus placebo. Reported the number needed to treat was 4.9. The summary: pharmacological treatment is well established for treatment of subacute herpes zoster pain. New high-quality evidence has been lacking since the last update, which was 2011. By the way, the show notes will have the link to this great article written by Dr. Adrianson, Dr. Jacobs, Dr. Venuge, Dr. Wojcik, I hope I'm pronouncing those names right, and of course Dr. Stephen Cohen, who was actually one of my former attendings at NYU before he moved on. So as far as local anesthetic topical agents go, lidocaine, capsaicin, cream patches, etc. They usually use 8% capsaicin, 5% lidocaine. Patients who received 8% capsaicin received significant pain reduction during 2 weeks to 2 to 8 weeks. After patients who received 5% lidocaine, they also had moderate pain relief after 8 weeks of treatment. Acute herpes zoster intracutaneous injections are used for acute herpes zoster pain. The effect of single intracutaneous injection with methylprednisolone combined with ropivacaine versus injection of saline alone in the allowed dermatomes showed significant difference in VAS score at 1 week and 4 weeks. Post-intervention favoring the intervention group. The treatment effect disappeared at the 12-week follow-up. 12 weeks post-intervention, the incidence of postherpetic neuralgia in the intervention group was 10% versus 29% in the control group. A 24-week post-intervention difference was no longer statistically significant. However, it may still be clinically relevant, the authors state. The effect of repetitive intracutaneous injections with ropivacaine and methylprednisolone every 48 hours for 1 week was investigated in randomized control comparing antivirals plus the analgesics to antivirals plus the analgesics and repeat injections. The intervention group had a significantly shorter duration of pain. The VAS scores were significantly lower in the intervention group, and the incidence of postherpetic neuralgia at 3 months after intervention group was 6.4% in the intervention group and 28% in the control group. After 6 months, the incidence continued to be lower in the intervention group. A complication of repetitive cutaneous methylprednisolone injections was fat atrophy, which was not reported in this study. So just summarizing the local anesthetics, they say that there are no new studies reporting the efficacy of capsaicin 8% for postherpetic neuralgia, but capsaicin 8% is still widely used in clinical practice, being approved in several countries. A lidocaine patch can reduce pain intensity in patients suffering from postherpetic neuralgia, but may be more beneficial in patients with allodynia. Intracutaneous injections may be helpful for short periods of time, while repetitive injections with local may reduce the VAS score for up to 6 months and can cause subcutaneous fat atrophy. Now getting to the real interesting part, the interventions. Epidural and paravertebral injections of local anesthetics and glucocorticoids or glucocorticoids. In the previous guideline, epidural injection with glucocorticoids, or corticosteroids I should say, and local anesthetic has an add-on therapy which was found to be superior to standard care alone, oral, viral, and analgesic medications for up to 1 month in the management of acute herpes zoster pain. An additional randomized control publication since the previous guidance demonstrated no difference between interlaminar and transfemoral epidural steroid injections for up to 3 months after the procedure. Previous guidelines reported high-quality evidence that paravertebral injections of corticosteroids with local anesthetic reduces the pain of the active phase of herpes zoster. Acute herpes zoster, a trial comparing efficacy of repetitive paravertebral blocks with ropivacaine versus dexmedetomidine to prevent postherpetic neuralgia, showed that the incidence of zoster-related pain was significantly lower 1 month after the therapy in the patient group receiving paravertebral block with dexmedetomidine. After 3 months, the effect was still significant in favor of dexmedetomidine. In a randomized controlled trial performed in 40 patients, no difference was observed in the occurrence of postherpetic neuralgia after epidural steroid injection administered via interlaminar versus transforaminal approach. In both groups, VAS was significantly lower at 1 and 3 months follow-up compared to baseline. This could be in line with the natural course of herpes zoster. Subacute herpes zoster. In retrospective study, transforaminal epidural injections was administered for acute herpes zoster-related pain, was associated with significantly shorter time to pain relief compared to transforaminal injections performed in the subacute phase. A randomized controlled trial found that continuous epidural blockade combined with opioids and gabapentin reduced NRS pain scores more than analgesic drug treatments alone during 30-day follow-up. However, both of these studies were low quality, so that's not very useful. Postherpetic neuralgia. This is what's interesting me. More interesting because this is what we see in the office, usually. A small randomized controlled trial demonstrated a decrease in NRS pain score 6 months post-treatment initiation for repeat versus single 15 milligram versus 5 milligram dexamethasone epidural steroid injections administered over 24 days. The trial also found increased likelihood of complete remission during 6 months follow-up in the group receiving repeat epidural dexamethasone, but this was low quality. They summarized epidural or paravertebral injections of local anesthetic and or glucocorticoids could be considered in the treatment of acute herpes zoster-related pain. For treatment of subacute postherpetic neuralgia pain, there was low-quality evidence supporting epidural injections. For the treatment of postherpetic neuralgia, the evidence supports continuous epidural infusion was low quality. None of the included studies for postherpetic neuralgia or postherpetic or herpes zoster investigate whether epidural paravertebral injections result in decreased pain compared to standard therapy. Post-RF, the previous guidelines assure that there was moderate quality evidence that post-RF of the intercostal nerve reduces pain in 6 months in patients suffering postherpetic neuralgia. There was also very low quality evidence that post-RF to the DRG reduces pain for 6 months in patients suffering from postherpetic neuralgia. Since this publication, the previous guideline, multiple studies have been published assessing the efficacy of post-RF, and here they are below. For acute herpes zoster, randomized controlled trial, 60 patients, high voltage bipolar post-RF of the cervical sympathetic chain versus sham. The treatment was repeated in both groups after 3 days. The VAS score in the post-RF group at each post-interventional point, 1 day, 2 days, 1 month, 2 months, 3 months, were significantly lower than the VAS scores in the sham group. At 3 months post-intervention, the incidence of postherpetic neuralgia was 16.7% in the post-RF group compared to 40% in the sham group. Another randomized controlled trial evaluating high-voltage, long-duration post-RF of the Gassarian ganglion was performed in 96 patients with subacute herpes-related trigeminal neuralgia. This study found decreased VAS pain scores at all post-interventional time points, 3, 7, 14, 1, 3, and 6 months compared to the sham group. Subacute herpes zoster in randomized comparative effectiveness study performing 120 patients with subacute trigeminal herpes zoster. A single application of high-voltage post-RFA to the Gassarian ganglion was compared to 3 cycles of conventional post-RF treatment. The authors found that the mean VAS pain score at different time points for up to 6 months during the follow-up were significantly lower in the high-voltage post-RF group, and the randomized controlled trial comparing post-RF to short-term spinal cord stimulation, a decrease in pain, and improved 36-item short-form health survey scores were observed in both groups at 6 months, and the randomized controlled trial performed in 72 patients post-RF of spinal nerves or peripheral branches of cranial nerves combined with 5-day infusion of IV lidocaine initiated 5 post-RF treatments result in greater pain reduction, less rescue analgesic, and reduced inflammatory cytokines at 2 months compared to post-RF combination with saline infusions. The lidocaine group also experienced lower incidence of postherpetic neuralgia pain than the saline group. A major limitation is that they did not account for the high natural recovery rate, which is a big deal. So, and then I think I've covered a lot here. I'm just going to summarize because this is a pretty long article. Summary: post-RF provides significant pain relief lasting over 3 months in patients with subacute herpes zoster and postherpetic neuralgia. Since few studies have compared PRF versus sham, it is not possible to calculate the accurate number needed to treat. There are no comparative studies comparing post-RF to the intercostal nerves to post-RF of the DRG, but both preclinical and clinical studies, including one performed post-thoracotomy neuropathic pain, demonstrate superiority of the latter, which is the DRG. Since the evidence for spinal cord stimulation for postherpetic neuralgia is of low quality and spinal cord stimulation is invasive treatment, more research is needed. There is low quality evidence for use of sympathetic blocks to treat acute herpes zoster related pain, but no evidence for the use of sympathetic blocks for the postherpetic neuralgia. Risks of treatment is really unclear for intrathecal methylprednisone, so it's not recommended. And of course, these interventions do have complications. This is a pretty comprehensive, well-written article, and they go over the settings of post-radiofrequency ablation. And I really highly recommend checking this out. I'd like to congratulate the authors because I really like this article, and it's giving me a little bit insight as well on how I may move forward with some of my patients. I had a patient with trigeminal post-neuralgia pain yesterday, and I don't do post-RFA here. Most of it's probably because of like most of you, it's not exactly standard of care, and it's not really reimbursed. So there's a lot of barriers to that, and then convincing a patient to pay for a procedure that really isn't as proven is kind of tough to do. But then again, it's a very safe procedure. Pulse RF is probably one of the safer types of interventions we could do. You're not really burning anything. So I have a patient with trigeminal neuralgia pain. I was going to do a topical sphenopalatine ganglion block just because it's the least invasive intervention I could do prior to injecting her trigeminal nerves at the foramen. So I may try that first in addition to pharmacotherapy. Anyway, thanks for listening. I hope you gained something from this podcast. Check out the show notes and the links. Check out the institutional memberships we have available, or come see me at one of the conferences, or shadow me for a day while I do these nerve blocks. And please rate the podcast and share it with your colleagues. Thanks for listening. Have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.